You can begin, Dr. Stieg.
Thank you very much, Tatiana. Good afternoon to everybody, and welcome to Everything You Need to Know About Meningiomas. This is part of our webinar series, was also part of my podcast called This Is Your Brain. You can see or listen to my podcast on any avenue or access media that you use, such as Spotify, Apple, whichever, and it covers a broad array of topics as it relates to the brain. Today, we're going to focus specifically on meningiomas, which are the most common primary tumor of the brain. They happen more commonly in females, but we will go through the four major questions that I believe every patient needs to focus on when they go to see a doctor. There's a lot of minor, related questions, but the focus questions are, what do I have? What does it mean to have it? What can I do about it? And then what are the risks associated with those choices? So why am I not advancing? There. So what do I have? Meningiomas, by and large, are benign tumors. 97% of them are benign tumors. And you can see on this slide, it's called the World Health Organization Grade 1, Grade 2, or Grade 3. The Grade 2s and Grade 3s are more aggressive. The Grade 2s can recur. The Grade 3s are referred to as malignant tumors. And there are all these different names that we have. But the vast majority, as I said, 97% of them fall into this category of called pseudomonas. And what that means is it's just a very dense tumor mass that grows slowly and indolently versus the type 2s, which can grow more aggressively and in a shorter period of time, as the type 3s, which are malignant and need additional forms of therapy. Today's conversation will focus on the 97% of the tumors that we're typically talking about. As I said, they're the most common type of primary brain tumor, which means that it's a tumor that originates in the brain, not a tumor that spreads from somewhere else in the body, which is referred to as a metastatic tumor. The peak incidence occurs at the age of 45 years, and it's slightly more common at a ratio of 1.8 to 1 in females. So when we're talking about meningiomas, we're talking about the covering of the brain. And you can see on this slide, there's the pia mater and the arachnoid, and then there's the dura mater. So here you can see the brain, the folds within it, which are called gyri, and then the creases between those folds, which are called sulci. And the box on the head is highlighted in this blow up. And a meningioma is typically a tumor that arises from either the pia mater or the arachnoid, and it can become densely adherent to the dura mater, but it arises typically from one of those three layers. How we classify meningiomas is basically their location. And you can see on this cartoon the common locations for meningiomas. And in the next several slides, I'll show you what are called MRI scans that highlight this. But there's the parasagittal, which means that it's around the midline, but it also can be over the convexity, over the round surface of your brain. There's olfactory groove. Then there's this area here where the pituitary gland sits, is called the sella. So there's paracellar. Then there's tumors along the skull base, which are called clival. Down at the base of the skull, there's meningiomas called within the foramen magnum. And then there can be tumors over the cerebellum. And last but not least, there can be tumors within the fluid chambers of the brain called intraventricular meningiomas. And we'll go through examples such as this. You can see here the varied examples of a meningioma within what's called the occipital horn or the trigone of the ventricular system. And you can see with contrast, these tumors enhance what's called homogeneously, meaning that it's a solid white mass. Without contrast, they have the same intensity or density as the brain. And then when we look particularly at imaging that focuses on water, you can see there's a little bit of brightness and flare image within the tumor mass itself. Then I referred to tumors of the foramen magnum, which the foramen magnum is the hole at the base of your skull through which the spinal cord goes down to the rest of your body. And you can see here, this is called the foramen magnum right at this level. And you can see this tumor mass right here. This again, these are, this is one with contrast. There's enhancement, but it doesn't densely enhance. And these are without contrast. And you can see how here's the tumor. It can encase the vertebral artery at this level, but it also is pushing what's called the brainstem out of the way. And here we're seeing how it uniformly enhances. And the important thing here is that it can grow around and encase structures such as the vertebral artery and other things called cranial nerves. The brain itself, it usually pushes out of the way. Here is another common location called the cerebellopontine angle. So this is the area directly behind your ear. You can see in this example on the right-hand side, this is your hearing nerve and your facial nerve, and the tumor is pushing them out of the way. This is the normal side. That's the beautiful part about the brain, is it's symmetric, and you can use one side for the control and the other side for the diagnosis. And the thing to notice here is that the common tumors in this region in the cerebellopontine angle are either vestibular schwannomas or meningiomas. Meningiomas are usually off-center. You can see here it's off-center in relationship to the 7th and 8th nerve. With vestibular schwannomas, the tumor is centered right around the nerves and it goes out into the ear canal. So that's how we differentiate it on the basis of the MRI scanning. I referred to earlier the parafalcine kind of tumor. So the membrane of the dura that divides the right and the left hemisphere is called the falx. And so this would be the right side, this would be the left side. And if it's parafalcine, it means that it's around and involves the falcine. This part is called the convexity. So it's a parafalcine frontal convexity type of meningioma. The important other anatomical structure here is up on the top here is the major draining vein where all the blood gets out of the brain called the superior sagittal sinus. And these types of tumors can frequently invade that area and not include it. And that limits the degree to which we can remove these tumors. Remember earlier I referred to the tuberculin cell, which is the bony floor of the front part of your skull. And you can see here how the tumor is pushing back on an area called your anterior chiasm, which is the visual tract. And so patients with tumors in this area will frequently present with changes or alterations in the vision out in the periphery in both eyes. You can see how the tumor is pushing back on the blood vessels within the brain, and it can also be pushing back on the pituitary gland. And on occasion, tumors in this tuberculum cella area will extend down into the cella, which is the area where the pituitary sits, and the patients can present with pituitary abnormalities as well. The sphenoid wing is the lateral part here of, it looks like a wing. You can see the normal side over here. And so the tumor is classified basically by the location where it is sitting. And the important thing here is that it invades the skull base where the carotid artery is, and you can see how the tumor is encasing the carotid artery. In addition to this, this is where all the nerves that control the eye motion, in this case for the left eye. So patients will typically present with complaints of double vision or blurry vision. In addition to pushing on the temporal lobe, the patients can present with seizures. And finally, we refer to Clivo, which is the bone on the base of the skull. These large tumors, as you can see, push on the brainstem, which is called the pons. And the symptoms that are created by these tumors, i.e., what does it mean to have it, are completely dependent upon where the tumor exists. So the first thing we worry about is what type of grade is it? And when we look at the what's called the Ki index, which refers to how the cells multiply and proliferate. The higher the number, the more rapidly growing. And then in addition to that, the more common you can see recurrence after there's been a complete resection of the tumor. So as the grade of the tumor goes up 1, 2, and 3, the cells multiplying go up 0.7, 2.1, and 11%. And then the recurrence rate, because they're more aggressive kind of tumors, also goes up. In addition to what it means to have it is where the tumor is occurring. And by that, I mean, if the patient has a tumor along the sphenoid wing, you remember that was over by the temporal lobe, a patient would present with either the double vision because the nerves controlling the eye are affected, or the patient would present with a seizure. They could have some short-term memory loss. If the tumor was occurring on the surface of the brain over the speech area, they could have trouble with formulating speech if it's up in front, or understanding speech if it's in back. If it grows over the visual cortex, the patient will have complaints of some visual abnormalities. And then down along the skull base, it can affect all of the nerves that are involved with eye motions, swallowing, control of heart rate. So all of those varied symptoms can occur and are completely dependent upon where the tumor is located. So the most important thing is, what can I do about it? And this is a very complex question because there are so many variables that we have to look at. And the variables that I talk about are on the right-hand side of this slide. Obviously, the way we would treat a 45-year-old patient is very different than I would treat an 85-year-old patient. Not because I'm discriminating about age, but we have, and the patient has, different expectations for what they want. And then 85-year-olds will commonly have more medical comorbidities, meaning they might have diabetes, they might have high blood pressure, they might have other disease processes that we have to take into consideration. In addition to that, the location is extremely important. How much manipulation are we going to have to do? Obviously, it's easy to take something out that's right on the surface versus something that's deep down on the bottom of the brain. And our goals of resection, remember that sphenoid wing meningioma I showed you that was invading the carotid artery? We can't get all of that out without leaving the patient with some neurologic deficits, so we don't do that. And then it also depends upon the size. Smaller tumors, less than 2 centimeters, can be very good candidates for other treatments like stereotactic radiosurgery, as long as the tumor isn't abutting important structures such as the optic nerve, the optic chiasm, the visual pathways. So where we try to avoid dosing with high radiation. If it's small enough, we can consider radiation, even in younger patients if they want to avoid surgery. And then obviously we have to consider neurologic status. Stereotactic radiosurgery doesn't work quickly. And one of the goals of the radiation is that the tumor stops growing. So if the patient already has deficits, stopping its growth won't be of much benefit if we want to get that function back. So we break it down into continued observation, stereotactic radiosurgery, or hypofractionated radiation, or in an elderly patient where we want to try to control growth, we'll use radiation that's not stereotactic, but only delivered to the area where the tumor is. We can do a combination of surgery plus embolization, or we can do combinations of all three, of radiation, surgery, and embolization. These have to be discussed specifically with each patient. You can only imagine that the recommendations I give a patient are based on all of these medical issues related to the tumor and to the patient's well-being and their age. And then we try to come up with a treatment format that seems most attractive, but also most effective. So we're really trying to maintain the quality of life or regain quality of life without any loss of neurologic function. So what are the risks associated with doing this? And in experienced hands, the outcomes with meningiomas should be relatively good. Now, I say that within the caveat that an elderly patient comes with a giant tumor and they're deteriorating in front of our eyes, and the family wants us to try to do something. That's a very high risk surgical procedure, and everybody has to understand that going into the situation. And the risks are somewhat dependent upon size, location, and the quality of the individual's life, the patient's life, before we start the process. One can imagine if there was a little 2 centimeter small 1 inch lesion up on the surface of the brain where it's not in what we call eloquent cortex. And by that, I mean speech cortex, visual cortex, motor cortex. If the tumor is not in that area, it's very straightforward for us to be able to go in and excise that lesion, and the patient would be out of the hospital within 2 or 3 days. Or if it's a small enough lesion, 1 or 2 centimeters, we can recommend that we just go ahead and radiate it. And hopefully, with smaller tumors, the radiation can be effective 90% of the time. We never have to do surgery. So I guess what I need to tell you is, if you go to a doctor and they only talk to you about one way to treat something, and they don't go through all the risks and benefits associated with either observation, radiation, surgery plus or minus embolization, or surgery in conjunction with radiation, I don't feel as though they have given you the full picture, the full spectrum, whereby you can determine what fits into their life. I think that as a surgeon, you are expecting me to provide you with a recommendation, and that's what I do for patients. But I also have to respect the fact that you as the patient know exactly where you are in your life. You have 2 young children, you have an important job that you're just in transition with. So we have to try to tailor the treatment to meet your both immediate and your long-term goals. So with that, I will open the floor to questions, and thank you all for your attention, and hopefully we can start some dialogue.
Dr. Stieg, I actually have a question. How does a meningioma grow in the intraventricular space if it has to be part of the meninges?
Well, remember I said it's part of the pia and the arachnoid, and there is pia and arachnoid lining the ventricular system, so the tumor can arise from that, which are part of the, people think of the meninges only as the dura mater, but it's not. The meninges are the pia, the arachnoid, and the dura mater.
Does anyone else have questions for Dr. Stieg? Elena asks, do meningiomas always continue to grow?
The growth pattern for them is variable. It's not linear. I tell patients that they grow on average 2 to 3 millimeters per year. That being said, one year they might grow a centimeter. I had one patient that we decided to follow, and unfortunately he came back a year later and was 2 centimeters larger. So we keep an eye on the patients. The average growth rate is 2, but it can also lay quiescent for a number of years. And that's why we many times will recommend continued observation, particularly meningiomas that are very calcified. They're, the entire mass almost looks like a bony rock on the CT and the MRI scan. In those scenarios, you probably have more time to continually watch the tumor.
Okay, the next question is from Maureen. Is a glomus jugular similar to a meningioma?
No, that's a very, very different tumor. The glomus jugulare tumor is a very vascular tumor. It's referred to as a paraganglioma. And it grows, it does grow down at the base of the skull in the cerebellar Pontine angle, but it's a very different tumor type. And because of its location where the 9th, 10th, and 11th cranial nerves come out of the brain and go out to the rest of the body, it presents considerable surgical challenges.
Okay, next up, Jay says that both of his parents had meningiomas. Are they genetic or are they more environmental?
Meningiomas can be environmental, particularly if children undergo a resection of a tumor and then they have brain radiation. There is an increased incidence of meningiomas in that patient population. Beyond that, it isn't genetic, meaning if mom and dad had it, it doesn't necessarily mean that you are going to have it. The only other factors we have to talk about, there's always been discussion about estrogen receptors, and that's why people thought maybe they were more common in females, but as that's been evaluated, no concrete evidence has ever arisen. There are some new genetic markers called NFT and Smoothelin that look at meningiomas, and they may be more common in convexity and skull-based tumors. And then the other molecular way that we look at these things is with something called methylation, and it seems that tumors that are more methylated have a higher recurrence rate. So in that patient population, we will follow patients more closely, and they may come to needing radiation subsequently.
Okay, in a patient you're observing who's asymptomatic, how often do you recommend an MRI?
It's a little bit dependent upon the patient and the size of the tumor. I mean, if it's and where the tumor is sitting. If it's the patient has said, I just can't have surgery right now, and it's a large tumor sitting in the cerebellar-pontine angle, I would typically get it at 3 to 6 months just to make sure that we're not getting behind on anything. Versus a small little convexity tumor, I would recommend getting it in a year's time, because even if it grew a centimeter, it wouldn't make the surgery much harder or the radiation much harder. So it's variable between patient. All of the comorbidities that I listed dictate how often we repeat the imaging. Once we know what the pathology is, say it's a WHO grade 2 or grade 3, there we're going to follow the tumors very closely every 6 months, versus a patient where I've taken the tumor out and it's the grade 1, we follow it on an annualized basis, once a year.
Next question is, if the patient were 86 years old and had a benign meningioma removed 10 years earlier, would you still recommend ongoing monitoring?
If the tumor has remained stable or non-recurrent at 86 years old, I'd ask the patient how comfortable you feel. I think you can spread out your follow-up to 3 or 4 years and not worry about it. But that's a conversation I have with the patient about how comfortable they feel.
Next is a pituitary tumor near the optic chiasm the same thing as a meningioma?
The pituitary tumor sits directly below the optic chiasm in the region called the sella. So yes, it is very close, but it's a very different tumor than a meningioma.
Next is it better to treat a small meningioma, 1.5 centimeter, with radiosurgery early before it enlarges?
I think that a 1.5 centimeter tumor meningioma, depending upon where it's situated, as long as it's not sitting by the optic chiasm or the optic nerve, you can treat it with radiation and follow it, because frankly, the radiation doesn't make the surgery any more difficult. Again, it depends upon, I've had patients where I've recommended they have small little meningiomas on the surface of their brain, and I've recommended getting radiated so that, we never have to deal with it surgically. And they tell me they want me to take it out surgically because they know that that's a cure. Okay. So again, it's that dialogue between the patient and the doctor. I think that treating a 1.5 centimeter meningioma, as long as it's not close to anything that's radiosensitive, like the optic nerve, the pituitary gland, the optic chiasm, is a reasonable approach. And then you continue to follow it. And if the tumor continued to grow because you didn't know what it was, and it is a WHO 2 or 3 type of tumor, you can still do the surgery.
We have time for one more. Can you talk about any additional therapies that might be needed after surgery, such as cognitive remediation?
Of course. Again, cognitive remediation is going to be dependent upon where the tumor is. So the area where a meningioma can cause problems with memory and what we refer to as executive function, meaning, how well do you rationalize your decision process? How do you understand the consequences of some action that you might take? How well do you control your anger and express yourself in a more equanimous fashion? Those are tumors that are involving the frontal lobe, so olfactory groove, sphenoidal, and tuberculin cell meningiomas, which can push on the frontal lobes. Once we take them out, or as the tumor grows, can cause these neuropsychological changes, such that we need to postoperatively provide some neuropsychological treatment. In addition to that, a huge tumor in the temporal lobe can affect some memory, and we may do neuropsychological treatment for a memory disorder. And in addition to that, we will also consider using neuropsychopharmacologists for patients that have these frontal lobe lesions, because they can help with attention, using drugs like Ritalin to help somebody stay focused. So yes, there are a number of scenarios where we will do what we call adjuvant therapy, meaning neuropsychological and neuropsychopharmacological treatment postoperatively.
Okay, I do think we have time for one more. Someone is asking if chemotherapy would ever be indicated if the meningioma were a grade 3.
Oh, yes. Yeah. And again, if it's a hemangioparasitoma, it may be used in that scenario.
Okay, we are just about out of time. Any last questions? Okay, thank you very much.
Thank you, everybody. It was a pleasure. Don't hesitate to contact us if you have any further questions.
Thank you.
Bye-bye.